Is final cementation of crown and bridge considered a dental emergency? Hi, I'm Dr. Jason Goodchild, a practicing dentist and the VP of Clinical Affairs for Premier Dental Products Company. With a lot of dental offices being closed to elective care and only providing emergency treatment, I wanted to go over a short review for definitive cementation. Just a couple of days ago, the American Dental Association published this guideline to help dentists understand better what constitutes a dental emergency. And as you can see from the red arrow, final crown and bridge cementation is considered a dental emergency if the temporary restoration is lost, broken, or causing gingival irritation. Remember that there are four major categories for definitive cement: glass ionomer, resin-modified glass ionomer, self-adhesive resin, and traditional resin. In the next slides, we'll go over the pros and cons of each category. For simplicity's sake, I tried to put together a cement product summary graph. Along the top of the graph are the cements: glass ionomer, resin-modified glass ionomer, self-adhesive resin, and traditional resin. Along the left side are some of their characteristics, things like aesthetics and strength, technique sensitivity, how easy are they to use. And in general, what you find is that the glass ionomer and the resin-modified glass ionomer, they are moisture tolerant, are easy to use, generally release fluoride, and have low technique sensitivity, versus the other side, the self-adhesive resin and traditional resin side of the graph. They provide things like increased strength, better aesthetics, but are generally harder to use. And so it's always a balance about which cement you want to pick. In many cases, it has the most to do with the preparation. But if I distill this graph down and add a bit of a stoplight approach, it will help you differentiate the pros and cons for each cement. Glass ionomer-based cements are relatively weak compared to resins. Resins look better than glass ionomers, but glass ionomers are easier to use than resins. Like I mentioned before, the preparation may ultimately dictate which cement you want to use. For retentive prep, you may be able to use conventional cementation, in other words, glass ionomer-based cements. For a non-retentive prep, resin would be a better choice. Or for glass ceramic materials, resins are recommended. And in this slide, I wanted to lay out a number of different products and kind of put them into buckets. With so many products in the market, I wanted to kind of give you some examples of where different products fall in this idea of glass ionomer, resin-modified glass ionomer, self-adhesive resin, and adhesive resin. And then we need to match the cement to the substrate. And I don't want to go over this entire graph. Feel free to pause the video if you'd like to read the graph in its entirety. But I wanted to provide some helpful hints when matching cement with substrate, and then perhaps how to prepare that substrate for cementation. When it comes to zirconia-based restorations, we don't etch those materials. We may cleanse them with a product like IvoClean. We may use a metal primer. And then you can see with good retention, we can use conventional cements, glass ionomer-based cements. Otherwise, you need to use resin cement. So how do we put it all together? Match the right cement with the right substrate for the right clinical situation. Doing so gives you the best chance for a positive outcome. Remember, we've assessed the retentiveness of our prep. We've determined what type of bond strength we need. Do we need aesthetics? Are we in an area where we can actually bond with resin, or we need more moisture tolerance? In the next slide, I've tried to put together a couple of simple graphs to help you choose the right cement. And here's a simple resource to help you match cement with substrate for the right clinical situation. Based on the stoplight approach, you can see green means a good choice, yellow is an acceptable choice, but perhaps something better exists, and red is not a good choice. There are two graphs, one for retentive prep and another for a non-retentive prep. I won't go through the whole thing, but I want to focus on the top graph if you have a retentive prep for zirconia restoration. Again, I mentioned before that conventional cementation may be okay. And then self-adhesive resin may be that Goldilocks where it kind of gives you better strength, maybe even aesthetics for a translucent restoration. Then if you go down to the bottom and then focus on zirconia again, You can see that conventional cementation might be okay, but you may need the strength of resin. Let's wrap it up with a quick case. In this case, we're going to see final cementation of an all zirconia crown on tooth number 30. Here's the clinical situation. You see the final preparation, the final impression, and the final model. After trying in the crown and making all necessary adjustments, interproximal, occlusal, I then clean the inside of the crown. You can use products like IvoClean or Zirclean to do this. I then chose the cement. In this case, it was ZRSEM Self-Adhesive Universal Resin Cement. First, I bled the syringe without the tip. After that, I put the mixing tip on and installed a disposable barrier sleeve. In this case, that's Sleeve It, again from Premier. And then when I was ready to dispense the cement inside the crown, I bled one more time through the tip, as you can see on the right, before dispensing the cement into the crown. After filling the crown with cement, I immediately seated it on the tooth. After that, I tack cured it with 3 seconds of light, 3 seconds from the buccal, and then 3 seconds from the lingual. After doing so, the cement is in its gel phase, and I can easily peel it away. And here you see me peeling it away very easily. After I've removed the buccal and the lingual excess, I'll remove the interproximal excess by having my dental assistant stabilize the crown with her finger, and then I'll floss. Once I snap the floss down through the contact, I'll pull it out horizontally rather than snapping it back up. And here you see the final restorations. But the most important thing to remember before you let your patients go is that after you tack cure, especially for a resin cement like ZRSEM, is that after you've tack cured and removed all the excess, the crown should be stabilized until the final set occurs. For this cement, it was 4 minutes. So after I tack cured it, removed the excess, I then had the patient bite in a cotton roll until 4 minutes elapsed. Then I knew the final set had occurred and the patient could be released. I hope this brief review of definitive cements and the cement categories has been valuable. Remember that best outcomes are achieved when we can match the right cement with the right substrate for the right clinical situation. Thank you, best wishes, and stay safe.